Welcome back for part 2 of our lecture on the child with respiratory dysfunction. Um, we are over halfway there. Time flies when you're having fun, right? Okay, next is pertussis or whooping cough. Pertussis is a respiratory tract infection caused by B. pertussis. It is highly contagious and particularly dangerous to young infants. This can be vaccinated against, and it was almost eradicated until recently. There's been a resurgence due to a decrease in vaccinations. It is highly contagious and transmitted through direct contact, droplets, or indirect contact with freshly contaminated articles. This begins with symptoms of an upper respiratory infection like sneezing, coughing, and a low-grade fever. After a week or two, the cough becomes more severe. It's most common at night, and it consists of short, rapid coughs followed by a sudden inspiration that produces a crowing or a whooping sound. It can be treated with antibiotics such as erythromycin. Some of the complications can include pneumonia, otitis media, weight loss, dehydration, hernias, and rib fracture. Nursing care includes encouraging oral fluids, ensuring adequate oxygenation. You may need to place the infant on its side during and following a coughing fit because they cough so hard that vomiting sometimes follows an attack. You want to provide humidified oxygen and watch for signs of airway obstruction such as increased restlessness, apprehension, and cyanosis. All right, now on to the meat and potatoes of the matter. We're going to talk about asthma and cystic fibrosis, which are long-term respiratory dysfunctions. Okay, we're going to start with a little patho of asthma because I feel like if we can understand what's really happening in these patients, then we can understand what to do to help them and why we're doing that. So the key players in asthma are the bronchi and the bronchioles. These are surrounded by smooth muscle, and this muscle helps to dilate and constrict that airway. During an asthma attack, these smooth muscles constrict and cause chest tightness and difficulty breathing. Inside the bronchi and the bronchioles are cells that produce mucus, which help trap the irritants and the bacteria we breathe and prevent them from going any further into our respiratory system. But during an asthma attack, the mucosa becomes extremely inflamed, which narrows it even further. And the air becomes trapped in the alveoli. And then those cells produce excessive amounts of mucus, which leads to a further decrease in the airflow. And then it also leads to coughing and wheezing as that air tries to flow through the narrow airway and around that mucus. It makes that wheezing, musical whistling sound that you hear. So the air at this stage is trapped in the alveoli. Therefore, the gas exchange isn't taking place, and the oxygen can't be transferred to the blood, and the carbon dioxide can't be transferred out of the blood. So they're going to have a decreased oxygen saturation, and they're going to have a buildup of CO2 leading to respiratory acidosis. The patient will feel like they can't breathe out or exhale all the way. When an individual is exposed to a trigger, an immediate inflammatory response happens, which results in a bronchospasm. This inflammatory process leads to recurrent episodes of asthmatic symptoms such as cough, dyspnea, wheezing, and increased mucus production. This is the most common chronic disease of childhood, so it's important that you understand this because you're going to see it a lot. Asthma is classified based on its severity. So there's intermittent asthma, where symptoms are less than 2 days a week. It tends not to bother them at nighttime or interfere with normal activity, and they have to use a rescue inhaler for symptom control less than 2 days out of the week. Mild asthma, they have symptoms greater than 2 times a week, but less than 1 time per day. Nighttime symptoms a month for infants and toddlers, and 3 or 4 times a month for children. They may have some minor limitations, in their normal activity and use their rescue inhaler greater than 2 times a week but less than once daily. Moderate asthma, they have daily asthma symptoms, and the night symptoms occur 3 to 4 times a month but not nightly. They're going to have some limitation to their normal activities, and they use their short-acting inhaler every day, which is their rescue inhaler. Severe asthma, they have symptoms all the time. They have symptoms at night greater than once a week in infants and toddlers, and every night for children. They're extremely limited in their daily activities, and they use their rescue inhaler several times per day. Asthma attacks vary in severity from patient to patient. Um, Asthma attacks are triggered by certain things, and it's important that we make sure that our patients understand not only their triggers, but also the early signs and symptoms that they are going to have an asthma attack soon. Triggers include allergens such as pollen or molds. It can be exercise induced, cold or changes in the weather, animals, cats or dog, pet hair, dander, irritants in the air like secondhand smoke, and then recent infections, upper respiratory infections. Now, the early signs and symptoms of an asthma attack vary from patient to patient, but we need to make sure that they are aware. Um, they may want to keep a journal so that way they can look back and see what was going on before they had that asthma attack. For example, we have a friend of the family whose son said he gets a nosebleed 1 to 2 days before he has an asthma attack. So she knows if he has a nosebleed that she needs to be looking out to use that rescue inhaler more often. The patient will also need to create and follow an asthma action plan that they'll come up with their doctor. The action plan is a plan that's created to help control their asthma, and it's based on their signs and symptoms and their peak flow meter results. The peak flow meter lets them know how their lungs are doing. The asthma action plan has a green, yellow, and red zone, and based on the symptoms, it will tell them how to treat their asthma with the prescribed medications. For example, if they're yellow, it may tell them they need to use their short-acting inhalers or get an albuterol nebulizer treatment, and then when to call their doctor. We also need to make sure to educate the patient about early warning signs of an asthma attack, such as they notice that they're less tolerant of activity, they fatigue easily or become short of breath more frequently. They may be coughing at night or throughout the day and have trouble sleeping. They may develop cold-like symptoms like sneezing, scratchy throat, tired or headache. They may become more irritable. They may wheeze more often, and then, of course, their peak flow meter readings may become reduced. Signs and symptoms that they're in an asthma attack, like we discussed earlier, they're going to have chest tightness and wheezing, coughing, difficulty breathing, especially exhaling because that air is getting trapped in the alveoli because of the swelling in the mucus. Now, if their trigger is exercise induced, that does not mean they need to quit exercising. There are some things they can do to help decrease the chances of an attack. They can warm up beforehand. They can have their rescue inhaler. They say 10 to 15 minutes before exercise starts, go ahead and use your inhaler. And that's something you can talk about with your doctor, and they'll let you know what you need to do. During cold days, let them breathe through their nose instead of their mouth, so that way you can warm up the air before it enters the lungs, because cold air can make those smooth muscles constrict and induce an asthma attack. And then if they already know they're sick, if they have a cold or respiratory illness, then that's a good time to avoid the exercise till they're feeling better. Asthma is diagnosed in several ways. First, they're going to look at the signs and symptoms. They may encourage you to keep a symptom journal. Then they can look at a chest x-ray, and the chest x-ray is going to show the hyperinflation that is characteristic of asthma. Hyperinflation because that air is getting trapped inside the lungs like we talked about. Then they'll follow that up with a pulmonary function test. This is the recommended test to confirm that asthma diagnosis. Not only does it confirm the presence of the diagnosis, but also the degree of the lung disease and how well they respond to therapy. So they can get this initially and then throughout the disease course. Um, During the test, they'll breathe into a mouthpiece connected to a spirometer that connects to a laptop. And this measures the amount of air that they're able to breathe in and out and its rate of flow. They take a deep breath and then they exhale forcefully. Then we talked about earlier the peak flow meter, and it shows how controlled a patient's asthma is and if it's getting worse. That way they know if an attack is coming up. It can let them know several days beforehand. You can use this with the asthma action plan that the doctor creates with you. It helps the patient know when they need to take their rescue inhaler and when they should go to the hospital for treatment. When you first start using this peak flow meter, they need to figure out what their personal best is. This is the highest number they reach over a period of time. And anytime they use this, they're going to be encouraged to breathe through it 3 times and take the best of the 3 readings. Not the average, but the best. They need to start using it when their asthma is under good control and use it once in the morning and once at night and record these medications before they take their medication. Sorry, but record the numbers before they take the medication. And then they'll know what their baseline looks like. If the reading they get is 80% or less than their personal best, then they need to follow up with that action plan. And lastly, skin testing can be used to identify certain allergens so that steps can be taken to avoid them. Sometimes just removing the allergen, like if it was cat hair, getting rid of the cat, can help to decrease the frequency of asthma episodes. Asthma medications are divided up into 2 categories depending on whether the medication is a long-term medication used to control your asthma or a short-acting medication used when an asthma attack is imminent or before exercise. The first one we're going to talk about are inhaled corticosteroids. These are classified as an anti-inflammatory, and what they do is decrease the swelling and mucus production. One example of this is a Pulmicort, and you can use that either by an inhaler or nebulizer. Make sure when you're using any of these inhalers that you wash your mouth out afterwards. You can also use a spacer with the inhaler, and that can help with that. And watch for signs and symptoms of thrush, which is the yeast of the mouth. You're going to have the redness in the mouth and the white plaques on the tongue. The leukotriene modifiers blocks the function of leukotriene, which causes the smooth muscles of the airway to constrict and plays a role in mucus production. So just like the corticosteroids, it leads to relaxation of those smooth muscles and decreases mucus production. This is your Singulair. This is not for an acute attack. Same as with the inhaled corticosteroids, this is a daily medication. A non-steroidal anti-allergy would be the cromolyn. It's also used for long-term. It stops the mast cells from secreting histamine, which decreases inflammation. This can cause temporary sneezing, burning in the nose, itching, watery eyes, or a bad taste in the mouth. And lastly, LABAs are long-acting beta agonists. So as we talked about when we studied neuro, beta agonists work on that fight or flight or the sympathetic nervous system. So that running from a bear response. When you're running from a bear, you want your bronchioles to dilate to help you move air more easily in and out. So that's what these bronchodilators do. LABAs are used for daily use and not for an asthma attack. They can also be used in combination with a corticosteroid in the same inhaler. Because this medication activates your sympathetic nervous system, watch for other things that the sympathetic nervous system causes side effects. So tachycardia, feeling nervous or jittery, and you want to monitor their heart rhythm for any dysrhythmias. Okay. Now we're going to talk about our quick relief or short-acting medications. Firstly, systemic corticosteroids that can be taken orally or IV, and they're used for short periods of time to gain quick control of asthma or to manage severe persistent asthma. Side effects, and this is why you want this to be a short-term thing, can include behavior changes, increased appetite, acne, the thrush of the mouth, stomach upset, or trouble sleeping. When the medication is stopped, these will all go away. More serious side effects can happen if this medication is taken for 2 weeks or longer, such as weight gain, worsening of diabetes, bone thinning, slowed growth, decreased immune system, stomach ulcers, and high blood pressure. So we want to use these for a short amount of time. Short-acting bronchodilators are used for asthma attacks or the prevention of exercise-induced, and we use that 10 minutes before, like we talked about. And your your asthma attack plan will let you know when to use these. The anticholinergics like Atrovent help to relieve the acute bronchospasms. When used in combination with albuterol, it can be extremely effective. All anticholinergics dry up secretions, so side effects you want to monitor for drying of respiratory secretions, blurred vision, and cardiac and central nervous system stimulation. You can give them sugarless candy to help with that dry mouth. And anticholinergics can often be used when the bronchodilators, the short-acting bronchodilators, can't be tolerated. Okay, this is kind of a lot on one slide, but to the left, you're going to see some examples of asthma drug therapy. And then to the right is an example of an asthma attack plan. Now, this can be made more simple for smaller children, but this is a good example I saw. Okay, status asthmaticus is a medical emergency, and it is what we call an asthma attack that is not responding to therapeutic measures, especially the use of albuterol or epinephrine. This can develop gradually or happen rapidly. Some of the defining characteristics is they're unable to speak full sentences or more than a couple words at a time because they're so short of breath. They may be agitated, confused, and then obviously just rapidly progressing short of breath. You'll see them start to have retractions and worsening wheezing and coughing. A child with asthma who sweats profusely, refuses to lay down, and remains sitting upright is in severe respiratory distress. Also watch for any sudden changes in their demeanor. If they have been restless and they're suddenly very calm or drowsy or lethargic, or they've been calm and suddenly they're extremely restless and irritated, then that can mean that they're hypoxic or in respiratory distress. So the treatments of status asthmaticus are aimed at improving ventilation, decreasing that airway resistance, relieving bronchospasms, correcting dehydration and acidosis, calming anxiety, and treating any other infections that may be causing it. You can administer humidified O2 to keep their sats above 90. They are given inhaled beta-adrenergic agents every 20 to 30 minutes times 3. Those systemic corticosteroids and IV fluids. And I will repeat, this is a medical emergency and we want to intervene quickly because these children are working very hard to breathe and they will get tired. All right, let's work our way through these asthma nursing diagnoses and see if we can think of some interventions that go along with them. The first one we're going to talk about is the ineffective breathing pattern. So if you have a patient that comes in short of breath, they're not moving air good, what can we do to help them out? What can we do to help them breathe? First, you can maintain the head of the bed elevated, help them sit upright. That can help to expand their lungs. You can encourage them to do pursed lip breathing when they exhale, and that helps them to push that old air out so that they can inhale new air. You can apply oxygen, of course. And then ineffective airway clearance kind of goes along with that. These patients have excess mucus buildup, so how can we help them clear that mucus? What can they intake that thins out the mucus? Fluids, that's right. So let's monitor for hydration. And then if you have a patient, this works on elderly patients too, that has excess mucus and you want them to clear that up, what are some activities you can encourage them to clear their secretions? Turn, cough, and deep breathe. So you can encourage this patient to take some deep breaths in and cough to cough those secretions up. We want to get them up and out. All right, for deficient knowledge, as you've seen, there's a lot of educating that needs to go on when your patient has asthma. A lot of medications, you need to make sure they understand, firstly, how to use that peak flow meter so they know when they're getting better or worse. Make sure they understand their asthma action plan so they know what they need to do when they're getting worse, what the signs and symptoms of worsening asthma or an impending asthma attack is. And then they're on multiple kinds of medication. So make sure they understand what each medication is for and when they need to take it. For anxiety, this is a scary situation for the parents and the children. Make sure that you help to keep the children calm because the more anxious and restless they get, the more oxygen they're going to need. So you want to make sure that you also look calm and that you do your best to encourage a calming environment. Activity intolerance, they can't breathe, they're extremely short of breath, so they're only going to be able to tolerate so much activity that's going to increase their oxygen demand. So what are some things you can do when your patient is activity intolerant? You can cluster care, try to do multiple things at once so you don't have to get them up and about and bother them as often. You want to encourage some quiet activities like reading, watching movies. The hospital I used to work at had a Wii gaming system that you could roll in there so that way they could play in there and keep the patients from getting up and bouncing around the bed. And just decrease the stimuli. Try not to let them have too many visitors in and out, siblings, having them jump around on the bed, stuff like that. Okay, now let's work through your patient comes in with an asthma attack. What is the first thing you're going to want to do when you see this child? They're retracting, they're wheezing, they're coughing. Um, they're only able to get a sentence or so out before they have to take a break. So what are we going to do first? First, you want to get those baseline vitals and apply oxygen to keep the SATs above 92 to 95%. Throughout this whole experience, you want to keep the patient calm and comfortable. Make sure they're sitting up and they're positioned in high fowlers to help them breathe. What kind of medications are you going to be given in this situation? Right, you're going to be given your short-acting bronchodilators and nebulized. You're going to be giving them the systemic corticosteroids through their IV. Assess their peak flow reading and watch for numbers that are 50% or less than their personal best. Auscultate their lungs, see if you can hear air moving throughout. And then after you give them the bronchodilators, some things you want to do is auscultate again to see how are we going to know that it helped. Right, you're going to see a decrease in the respiratory rate, a decrease in the wheezing, air moving more easily. You might see the color starts to come back to them, the retractions are reduced, and those peak flow reading numbers are going to improve. All right, this is an example of an asthma education sheet that they may send home with the family. We've already discussed asthma education pretty thoroughly, I believe, but you want to make sure to teach them to avoid their triggers, how to administer the medication, symptoms of an asthma attack and what to do if they have one, protection from infection, and breathing exercises. All right, we are going to wrap this thing up with cystic fibrosis. So stick with me, we're in the home stretch. Cystic fibrosis is a genetic disorder that causes a mutation in the CFTR gene, which is the cystic fibrosis transmembrane regulator. This gene makes up the glands in our body that transfer secretions such as mucus, tears, sweat, and digestive enzymes. It also controls the sodium and water transport in and out of the cells. Therefore, these channels within our glands that make up our sweat, mucus, tears, and digestive enzymes don't work properly. So the substances these glands produce don't look and work like they should. For example, the mucus that we produce in our respiratory tract and our GI tract should be thin and slippery to help lubricate structures. However, and remember this, the mucus in CF patients is thick and sticky. This has repercussions all over the body, but mainly the respiratory system, GI system, and reproductive system. It also causes the sweat of these patients to be high in salt content. Okay, let's knock out the GI system first before we look at pulmonary. That thick and sticky mucus causes blockages throughout the body, including the GI system. One of the initial symptoms that doctors look at in newborns to see if they have CF is a meconium ileus. As you know, meconium is that first stool, and this sticky mucus slows down the intestines and leads to constipation and an ileus. The pancreas is an organ that is also greatly affected by CF. The pancreas secretes the enzymes protease, amylase, and lipase. These are secreted into the small intestine via the pancreatic duct, and they help digest proteins, vitamins, and fats. However, that duct becomes blocked by that thick and sticky mucus, and the enzymes stay in the pancreas, which can actually cause fibrosis of the pancreas and lead to CF-related diabetes. But when the patient is not receiving those pancreatic enzymes, the proteins, fats, and vitamins that they eat pass straight through and into the stool because they're not broken down to be absorbed by the body. This causes weight loss, malabsorption, nutrition issues, delayed puberty, and greasy, odorous stool, bloating, and abdominal pain. The stool is greasy because of the fats that are passing through, and it's odorous because of the proteins. Because of this, the patients will need to take pancreatic enzymes for the rest of their life. They will also need to take fat-soluble vitamins that they weren't able to absorb. You can remember these as DECA. That's vitamin D, vitamin E, vitamin K, and vitamin A. That mucus also causes infertility in men and women and delayed puberty and amenorrhea. This thick and sticky mucus wreaks havoc on the respiratory system as well. First, it starts out in the nose with nasal stuffiness and extensive sinus problems. It then leads down to the respiratory tract. It fills the structure of the lungs and causes blockages of the airway. Over time, this leads to obstructive pulmonary diseases like emphysema. This mucus also makes them very susceptible to lung infections that can cause permanent damage to the lungs. This thick and sticky mucus creates perfect conditions for bacteria to live in and to thrive. The testing for cystic fibrosis starts in newborns, where they have a blood test that analyzes the DNA for the presence of the applicable mutations. Cystic fibrosis can also be diagnosed with a sweat test. This is a painless test that measures the amount of salt in the sweat. And you can see a picture of that process here on this slide. The chest x-ray they can run also reveals characteristic patchy atelectasis and obstructive emphysema. They also do pulmonary function tests that are used to test the level of lung function. Because CF affects many different systems in the body, patients who have CF are on a wide variety of medications, like stool softeners, the pancreatic enzymes, nasal sprays, vitamins, antibiotics, anti-inflammatories, mucolytics, and bronchodilators. The clearance of mucus is a huge part of everyday life in a patient with CF. First, they can do daily chest physiotherapy or chest PT. This helps to drain the airway of that thick and sticky mucus. They use postural drainage, where they get in certain postures that use gravity to help it drain out. And then they do percussion and vibration, and that facilitates the breaking up of the mucus and draining it from the lung lobes. Then they also follow this by a huff coughing, where they cough in a certain way that helps to clear the secretions, and you'll see an example of that in a following slide. This part is a huge part of treatment for CF patients. Chest PT, they can either use certain equipment, or they can cup their hands and percuss over the lung fields, or someone will do that for them. Some patients use vibration with a special vest, and then, like I said, the huff coughing. Patients usually perform this 2 to 4 times a day or more, depending on if they're fighting an infection, and these sessions can last from 20 minutes up to an hour. You want to do these sessions when the stomach is empty to prevent reflux of food and vomiting. You want to do it 1 to 2 hours after a meal, like in between meals. You don't want to do it right after because they could vomit, or right before because the taste of that thick, sticky mucus in their mouth can decrease the appetite, and we want to make sure that they have good nutritional intake. They also use something called a flutter mucus clearance device, which you can see here in the picture, and it helps to remove the mucus. It's handheld and it can be used without assistance. They also take something called Dornase alpha, which decreases the thickness or viscosity of the mucus. It's given every day, and it only has minor adverse effects. Mainly, it can change their voice and cause laryngitis. And then any pulmonary infections they may have are going to be treated aggressively. Bronchodilators are usually administered before the chest PT to help open up those lung spaces, and then to aid in mucus clearance. Okay, this is an example of home care for cystic fibrosis. It varies between patients, just like an asthma plan varies between patients. The diet of a patient with CF is extremely important. Firstly, they take pancreatic enzymes with all meals and snacks. These are capsules that they are to swallow them. They're not allowed to chew or crush them. If the patient can't swallow the capsule, it can be opened up, and the insides can be put in acidic food like applesauce. Don't mix it in alkaline-based foods like yogurt pudding or ice cream, because that will inactivate the enzyme. For example, I had a pediatric patient who was nothing by mouth and had a G-tube for feedings, and so the pancreatic enzyme capsules were opened up and sprinkled on top of a mixture of applesauce and a little apple juice and put through the G-tube. How do you know if the patient is receiving an adequate amount of enzymes? Think about that. These pancreatic enzymes, or the enzymes that break down the fats, proteins, and vitamins. Right. You're going to look at their stool. If that stool is no longer greasy or odorous, and they're free from abdominal pain or bloating, then you know that they're getting the right amount of enzymes. Like I said, you want to administer these between meals and snacks. You want to encourage a high water intake that thins the mucus in the gut. And they also use Miralax daily to prevent constipation. You want to monitor for bowel obstruction signs like no bowel movement, pain, not able to pass gas, distension, that kind of thing. You want to make sure that they have a high protein, high fat, and high calorie diet. That is because they're not breaking down these things as frequently, so you want to try to replace that as much as possible. And then also make sure they take in water-soluble forms of vitamins A, D, E, and K. Like I said, DECA is how I remember that. You want to monitor their growth to make sure that they're taking in enough, and you want to treat their GERD. And lastly, let's look over some nursing goals for CF. You want to improve their airway clearance. This is the main #1 goal in CF because of this thick and sticky mucus. You want to monitor for signs of respiratory distress, teach the child how to cough effectively, that huff cough, examine the mucus that's produced, make sure that it's not getting thicker, increase their fluid intake to thin that mucus out, and encourage the child to drink extra fluids. The next one would be improved breathing. You want to maintain them in a semi-Fowler's position. If they're having any problems, use pulse ox, keep that O2 sat higher than 90%, and give oxygen as ordered. Perform chest PT as ordered by the physician. And teach them how to exercise to help loosen the thick mucus. Teach them to prevent infection, good hand washing, hygiene habits, restrict people with an infection from coming in contact with the children, and administer antibiotics as prescribed. We want to maintain adequate nutrition, increase the caloric outtake, provide that high calorie, high protein, high fat diet. You can use snacks such as peanut butter and cheese. Make sure they're taking their enzymes. And then report any changes in bowel movements, weight, or growth. Reduce the anxiety, provide age-appropriate activities that help to alleviate the anxiety and boredom when they're stuck in the hospital. Encourage the family caregiver to stay with them when they're in the hospital and allow them to have familiar toys or mementos from home. Provide family support. You want to give the family and the child opportunities to voice their fears, their angers, their anxiety, respond with active listening techniques, and provide emotional support throughout the entire hospital stay. Okay, that wraps up our material from chapter 21. I know that was a lot that we covered, and it was pretty detailed. So after you finish listening to this, I want you to take a minute and think about what is your muddiest point? What did you have the most trouble understanding? Doesn't quite make sense, or you don't quite grasp? If you will, jot that down and bring that to class with you. And as we go through, if there's anything that isn't cleared up, let us know, because I'm sure if you have a question, somebody else probably has that same question. All right, thank you.